Good morning, good afternoon, good evening. A very, very welcome to you all. Thanks for being here, everyone. I'm Tania Pastrana, co-chair of the EAPC reference group on primary palliative care. Together with Scott Murray, Daniel Monday, and Nicole Forrest, we prepared this session. Led by Dan Monday, we have reviewed theoretically, historically, and empirically the concept of primary palliative care and noticed how differences are emerging about what it includes. We think it could be very useful to have a clear definition for international uses. In Rotterdam, we brought together enthusiasts from different regions of the world to have a global dialogue on this issue and ask them to provide a regional panoramic and some successful examples. Today, we want to continue this discussion and ask our speaker to summarize and then to focus on one successful model. We want to learn more about how primary palliative care looks like in Africa, Asia, South America, Canada, as well as Europe. We are encouraged by each other in a truly worldwide forum. In this first part of the session, we will hear briefly our experts from each continent. And I will share who are with us today. Can you see it? Well, from Europe is Professor Scott Murray, Emeritus Professor from Primary Palliative Care at the University of Edinburgh and founder of the Reference Group of Primary Palliative Care of the EAPC. Also, the Professor Kerry Thomas, creator of the Gold Standard Framework of the UK, will be with us. Then from Africa, Oladayo Afolabi from the Comprehensive Chronic Care and Palliative Care within Primary Health Care of the African Palliative Care Association. Then from Asia, Dr. Shamat Fernando, chair of the Special Interest Group on Primary Palliative Care of the Asia Pacific Hospice Palliative Care Network. And from Latin America, Dr. Nicolás Davibovich, co-founder of the Latin America Working Group on Palliative Care and Primary Care, and also former coordinator of the National Palliative Care Program of Argentina. And from Canada, Professor José Pereira, co-founder of Pallium Canada, is professor of the Faculty of Medicine and Institute of Cultura y Sociedad of the University of Navarra, Spain, and professor of the Division of Palliative Care in the Department of Family Medicine at the McMaster University of Canada. In the second part, the Professor Daniel Monday will lead a panel discussion around this innovation in different countries and around the best language to use to describe this. Please insert any comments or questions in the Q&A box, and we will try to respond to this. Now, please join me in welcoming Professor Scott Murray and Professor Kerry Thomas.
Thank you very much. It's a real pleasure to be speaking this morning and to see so many people entering into the Zoom. It's a real pleasure that there's hundreds of people coming from throughout the world. So everyone is most welcome indeed. So each continent is having 10-minute slot. And my first slide will show you that we're breaking, Kerry Thomas and I are sharing the first 10-minute slot on a primary palliative care in Europe. Here we go now. So for our 10 minutes, I'll be mentioning generally about primary palliative care in Europe for 5 minutes, and then Kerry will talk about the shining example of the gold standards framework in the EU. Next slide, please. So primary palliative care in Europe, we're trying to define what we mean by this and describe what's happening in the continents. Next slide, please. So the first term was coined in the UK, in fact, internationally by Roger Charlton, a GP in 2002, who wrote that book there. Next slide. A couple of years later, a few of us had an editorial in the BMJ when we sort of consolidated developing primary care as a term and explained that it was primary care professionals having potential and working together in primary care. Next slide, please. And more recently, Dan Mundy and others, a group of authors you can see here, some from India, Africa, France, and myself from the UK, we clarified that we mean by in Europe, primary palliative care is palliative care practiced by primary care workers, who are the principal providers of healthcare for people. So that's the working definition that's being developed and is currently sort of used throughout Europe, and the WHO Europe especially. It has a broader remit sometimes. It's been described slightly different in other continents, and we'll hear about that later, and that'll be interesting to see, to describe what's actually happening and what should we call it, because we want to have some common language so we can all encourage and work together. Next slide, please. But since the last update that Tanya did a couple of months ago in Rotterdam, there's been an exciting meeting of the WHO European Primary Care Policy Group. So this was a big primary healthcare policy meeting a couple of months ago, and one thing they wanted to do was they said, we have the potential, we want to integrate palliative care as an important part of development within primary care. So they invited our group along to actually suggest what this would be all about. Next slide, please. And of course, 5 years ago at Astana, around that time, it was very much on the agenda to have palliative care in primary care integrated into primary care. So this is primary care being integrated with palliative care. Next slide, please. And really at that WHO meeting, we explained to the general practitioners there what a great potential that and nurses there is for primary care to deliver palliative care. First of all, because in primary care, we deal with people with all illnesses over a matter of time. We have people early in their illness trajectory, so we can actually help people when they start to become ill and not just at the very end. We can deal with all dimensions of need. We can actually deal with all settings and all countries, this primary care. So really, there's a great potential, we feel, to actually deliver for palliative care for all. Primary care is really important. Next, please. And on the definition, here's palliative care should run alongside curative care. And this article has been cited, not read, just cited over 1,500 times. So using this vocabulary as we're developing about primary care in Europe. Next, please. So what we do in Europe? Well, in Europe, actually, we met together in a task force and developed a toolkit, and we had authors from all these different countries. Next slide, please. And this shows the authorship. Nurses and doctors and other allied health professions working in primary care got together to make a document so that they could use it to take forward primary care in their own country. Next, please. And to vie with each other to develop. And so now there is a toolkit where we look at actually policies in each country, education, services, and medicine that might be available. And the group over the last, volunteer people throughout Europe have been translating it. And so in the main European languages, translations of this toolkit is videos to support that. And there's some links with other documents there to see what we're doing. So next slide, please. So doctors in all these different countries have been going ahead to try to improve palliative care policy and other aspects in their country, and we've been encouraging them to do it. And that's been a great success that different countries are doing this together, learning from each other. This document's got lots of links as well. Next slide. So this document actually highlights that a core issue in primary palliative care is actually identifying people, because maybe specialists don't do that quite so much. So we've taken a focus on how do you identify people. This is a key step. It's a stenosis in the pathway. Next, please. And so there are various tools. This is a supportive pathway indicator tool, and we flagged this up as a potential way of doing it. There's other ones that Kerry will talk about as well. Next, please. And this is to identify people who would benefit from supportive or palliative care. And there are different illnesses that come. So people with all these types of illnesses may qualify because of this advancement in that area. Next, please. And this has been, again, translated into lots of countries throughout the world as well. And some countries don't need it translated from English, but many countries are being translated into, and even patient-held ones that they can sort of self-identify for that. And there's a low-income country one. Next, please. Nearly finished. So just one other thing from Scotland that's happening is that electronic care coordination summaries are becoming quite important now. And these are summaries, as we can read here, when someone gets an advanced progressive illness with the patient's consent, we can help coordinate their care by actually starting a key information summary. And that's an electronic document. And if people have got this, they're more likely to die in their place of care. Next, please. These can be generated automatically by all family doctors, and all family doctors in Scotland have the same system, and they have access to this, so that some data can be automatically extracted on a daily basis from the patient's clinical record and sent to the GP, out of hours, emergency department, ambulance, NHS, and specialist departments. So this is a sort of summary of the advanced care plan, so that these people can have it to care for folk in the emergency. Next, please. And of course, if they've got one of these, the out-of-hours service will think, hey, this person has got this attached. And the beauty of these key information summaries is that we can allow you to see actually and think of outcomes of primary care. Because this study done 2 or 3 years ago in Scotland shows actually when people actually identified for a key information summary. And this shows, in fact, that if you take the green line here, it shows that people with frailty or dementia get a key information summary and advanced care planning 88 weeks before they die. And when they die, 73% actually are covered. Cancer is the opposite extreme, people only getting that on average 15 weeks before, and the coverage rate is spent. So I just present that as a way that we can start looking at outcome indicators for spread or coverage of palliative care in the community, or as we say, primary palliative care. So thank you. I'll hand over to Kerry now, please, to actually give this great shining example of, especially in England, how palliative care has been developed in primary care. Thank you, Kerry. Great pleasure that you're here to share with us.
Thank you, Scott. Carrie?
You're muted, Kerry. Can you unmute?
Thank you. Is that all right? You were getting away with it there, Dan. Thank you very much for inviting me, and delighted to be speaking today, and welcome to you all. And thank you, Scott, for inviting me. Some people might know about GSF. We're now celebrating 25 years. So I was just going to give a bit of a whistle-stop tour, and I've put a link to a video in the chat, but Nicole might add that as well. So as a GP for most of my working life, we tend to think of population-based end-of-life care. So people are born, they live, they die. And in that time, there's a period of time when they're in the last years of life. And that's the time that as a GP, you start caring for them. Well, you carry on for all their lives, but this is an important time. So it isn't just in the dying stage. Also, most now in the UK die of age-related conditions. Dementia is the biggest killer, frailty and multimorbidity. So this is the situation now. So the vast majority of people are dying of these conditions. We have about 650,000 deaths in the UK, of whom some are being cared for by specialist palliative care. Of course, we work with palliative care colleagues, but we believe everyone should receive gold standard end-of-life care, no matter where they are and what condition they have. So an underpinning ethos of this is quality end-of-life care for all with any condition in any setting given by any care provider. And that's why this primary palliative care group is so important to discuss this. And we take the general thing, but 1% of the population are in their last year of life, 1% of the population die each year, 30% of hospital patients and 80% of care homes residents. And who gives the care? We have in the UK about 10,000 palliative hospice and palliative care specialists, brilliant team of people. But the vast majority of care is given by the generalist frontline providers, primary care, care homes, hospital, domiciliary care, prisons, others. And the workforce is over 3 million when you add up the health and social care. And of course, the fantastic population and the community and the carers, this is a really important bedrock on which everything else develops. But we believe end-of-life care is everyone's business, everyone's involved. And in fact, most hands-on care is given by generalist frontline staff, health and social care. So we need both well-trained generalists and access to specialists. And as we're moving to more age-related conditions, this will be even more important, and the social care input is even more important. So this is what we concentrate on, the enabling generalists. Where are we with GSF? A summary: with now the leading training provider in end-of-life care in the UK. It's evidence-based quality improvement. It's very much step-by-step end-of-life care training for use for 25 years across the whole UK. for people at any time, in any setting, in any care provider. And it's about enablement, mobilizing the workforce, releasing talents, and democratizing end-of-life care. And now we formed a new coalition of frontline care for people nearing the end of life, and written to government and having a concerted view together of the health and social care organisations who belong. Where are we now? In terms of GSF, we spread it to 12 different training programs and settings, although sometimes we do a few together, but right across the country, and also this international work. Alongside the training, we developed a quality assurance and accreditation, which is co-badged by independent organisations. And over the years, GSF principles are mainstreamed in every GP practice, in NHS policy and CQC. And you see Identify, Assess, Plan coming out in what Scott just said as well. But importantly, when you look at the whole system, the whole population across health and social care, across all different providers, GSF can be a language, a common language across those areas. So in England now, we've got 42 integrated care systems and people using GSF across the settings. So when I look back at 25 years, what happened? Well, 25 years ago, as a GP in Yorkshire, I started doing some work with 12 GP practices. We had NHS support. We had this thing called QOF, which mainstreamed improvements in end-of-life care, palliative and end-of-life care. And we built everything on this Identify, Assess, Plan. And we measured, and we found that people could identify, assess, plan, and get to good numbers of early identification. And then by 2009, as Dan knows, who did a lot of the research for this, it spread to every GP practice, 95% of all GP practices, and then spread to every setting where people were identified and put on our version of the electronic register, EAPCs. Sometimes they call them gold patients and added things like Gold Line and Airedale. And often people quite like the concept of gold patients. They assess clinical and personal needs and plan proactive, personalised, coordinated care. So more were able to live and die where they choose and reduce crisis and hospitalisation. And we've got lots of data on this. I haven't got time to go in it, but lots of fantastic evidence of decreasing ED attendance, decreasing hospital deaths, and 80% of people dying where they choose once they've gone through this as an integrated care system. So 25 years on, we reflected it's now the bedrock of community palliative care used in hospitals as well, and integrated palliative care. So all GP practices use the basic GSF, it's called different things sometimes, and we've trained over 5,000 teams, 500,000 staff and 2,000 teams accredited, some fifth time, which means more than 16 years since training. And the GSF principles are now mainstreamed in policy, and we do some work internationally. There's a video, I put the link of on the chat, and Nicole might do that again. But if you wanted to see the video about our celebration, really, of 25 years, it feels a very long time. Do have a look at that. The three basic steps, which you've heard before: identify, assess, plan. Of course, it's more complex than this. Of course, the details are greater than this, but identify to be more proactive. And we have a thing called proactive identification guidance that came out from 2004 when we were first asked to do this by the BMA to do with QOF. So this is the guidance, and SPICT is similar, and the tool matters less than the whole concept of it, really. Person-centered, which is advanced care planning and clinical needs, and coordinated so that more people die where they choose and reduce emergency hospitalization. So they're the basic steps underpinning everything. We've got lots of work going on internationally over the years in two different areas. One, Horizon Life Care, GSF International, advice, GSF adaptations, licensing, things in Europe, Canada, Singapore. It's really good to hear from Jose what's going on in Canada. But that's an example of us in Japan a few years ago. And then in the last 8 years, the Andrew Roger Trust, and we're now developing African grant programs for any listeners in Africa, and we call it PEG, Planning Early, Going for Gold. And this was an example of Abundant Life in Cape Town. So active work, but not imposing. It doesn't have to be GSF, it's not tied to that, but it's just the principles and the energy and the resources and the experience of what we've done in the UK might be of use to you in your countries. So the main messages, and please do contact me, either one of the emails and look at the gsfinternational.org.uk website if you want to know more. Start with people's needs. End-of-life care is everyone's business. We don't start with the service. We don't start with palliative care service. We start with people, especially aged people with frailty, dementia, and multimorbidity. Enabling frontline generalists and primary carers. They have skills that need to be released and affirmed. We build this on 3 steps: identify, assess, plan, but then there's 7 underneath that, 7 sub groups. Very important to align with national policy, to both align with implementing national policy, but also to influence national policy and think about the whole system care of the population. This is certainly something that's becoming really important in the UK. The benefits of GSF end-of-life care as a whole: the better experience for the person and family, less dissatisfaction complaints, fewer emergency admissions or interventions, which of course saves time and money, greater satisfaction delivering best practice, staff confidence and retention, workforce crisis, so very important to consider our workforce, and a clear recognised training and accreditation and independent validation. I would say always it is possible to grow a movement from small grassroots beginnings, and we think GSF can be of help in other countries, and do contact us if you needed more. But keep your big vision. This is so important. This is crucial. What you do in your country is so important. So thank you very much. There's my email and the websites and a whistle-stop tour, but thank you very much for listening.
Thank you very much, Kerry. We move to Africa, and it is a pleasure to introduce you to our next speaker, Dr. Oladayo Afolabi. Welcome.
Yeah, thank you very much, Tanya. So if you can share the screen for my presentation, please. Thank you. Let me just start. So thank you. I'll be presenting on behalf of the African Palliative Care Association Comprehensive Chronic Care and Palliative Care within Primary Healthcare Reference Group. Is a very wordy name. It's mouthful. And what I'll majorly be talking about today is how we've defined palliative care within Africa, and also an example, which is the Integrated Primary Palliative Care Program that my PhD developed and tested and evaluated in Nigeria. So we know that the previous definition of primary palliative care that was quoted by Professor Murray earlier, it made 4 critical assumptions from our review of it. First is that primary health care provides integrated care for people in their communities. And the second assumption it makes is that primary health care delivers chronic disease management, which actually from our research in Nigeria, we found that while primary health care should deliver chronic disease management, the years of socialization to acute disease conditions and infections has meant that primary health care has majorly focused on first aid for acute conditions and treating acute infections, maternal and child health problems, and also immunization. So the third assumption is that referral systems for specialist collaboration are well developed, which is not always the case. And lastly, the fourth assumption is that people living with serious illnesses are willing to go to primary healthcare facilities for care. In poorly developed healthcare systems or developing healthcare systems like we have in Nigeria and many other African countries, the primary healthcare level does not necessarily serve as a gatekeeper for the tertiary healthcare facilities or the secondary healthcare facilities. This means that patients can just go directly to the tertiary healthcare facilities for their care, even for just when they have symptoms like headache. So it is important to acknowledge these 4 critical assumptions, and that is why we set out to, 1, understand what is integrated primary palliative care in low and middle income countries, with the purpose of really trying to map what is going on in Africa within the literature. And then the second thing we tried to do was a consensus definition through a modified nominal group technique to understand what is our common understanding of primary palliative care from an African perspective, considering our limitations and the assumptions from earlier definitions.
Sorry, Dale, can you just check that we're showing the, I'm not sure where we are with the slides.
Okay, so we're on slide 3. I'm going to slide 4 now.
Okay, perfect. And if you just tell me to move on to the next one when you're ready.
Okay.
Yeah,
Yeah, thanks. So
Is that the right
slide
one?
4. Yes.
That one?
Yes.
Perfect.
Thank you. So what we've done with, and I presented this at the last EAPC meeting, the research, what we've done with our scoping review is to try to understand how services are structured within the evidence for primary palliative care within Africa and within low and middle income countries more generally. And that is just a pictorial reference of what we found within the evidence, that primary palliative care is either delivered by generalist physicians within primary healthcare clinics or specialist palliative care providers coming to deliver care within primary healthcare clinics. And in some cases, primary palliative care is also delivered, generalist palliative care delivered by family physicians or generalist medical practitioners within secondary and tertiary care facilities. And also there's a lot of involvement of community NGOs and community-based organizations and faith-based organizations in delivering primary palliative care. So our consensus definition that we tried to do was that primary palliative care in sub-Saharan Africa will be palliative care and end-of-life care that is provided by trained health workers at the first point of entry where people access healthcare services. And this means, importantly, primary is not defined by place of care, but by how people access care. So that's a very important point that I just want to highlight within our definition. And we've submitted this for publication, and we are hoping it's accepted. So also in terms of trained healthcare workers, one of the clarifications within the definition is that trained healthcare workers include, yes, next slide, thank you, include practitioners with a registered qualification, community health workers who meet the training requirements in the country in which they practice, and also sometimes approved traditional and complementary medicine practitioners who cooperate with the primary healthcare clinics, and then palliative care specialists operating in a primary healthcare or community setting. So I'll move to the example from Nigeria. So we developed the integrated primary palliative care intervention, which was then evaluated and tested from 2018 to 2022. What we've done was Nigeria, as we know, remains in category 3A of the Global Palliative Care Atlas, the isolated provision of palliative care. And integrating palliative care within tertiary hospitals in Nigeria has progressed slowly, but it's really moving fast. And but it definitely fails to meet the need at the population level when we consider that tertiary healthcare facilities only constitute about 0.03% of healthcare facilities in Nigeria. And that was one of the reasons why we set out to develop this program. And one of the things within the program is we developed a feasible theory of change to really highlight how does all these factors work together and to understand the mechanism of actions of the different components of the intervention. And then we adopted a multidisciplinary approach to training and development and implementation. So we used we looked at the WHO guide for integrating palliative care within primary health care, which Professor Murray earlier shared. And we found that the training was segregated as different training for medical doctors, different training for nurses, and different training for community healthcare workers. And in countries like Nigeria, when within primary healthcare, you might not find a medical doctor, or you might not even find a nurse sometimes. So it's only the community healthcare workers that are there. So they need an understanding of some of the basic principles of what is going around. And also the community healthcare workers in Nigeria are trained up to 4 years for the community health officers post-secondary education, while community health extension workers 2 years post-secondary education. So there's also this diversity within Africa around what's really, who is a community healthcare worker, who is a village healthcare worker, what is their training and competency level. And this is one of the challenges we had within the African Palliative Care Association network. So what we've done is, I like the framework that Professor Carey shared earlier of identify, assess, and plan. We used a different framework, which is act promptly, assess, communicate, teach, plan, and refer promptly. Because we found out that it's difficult, especially when it's a community healthcare worker that is dealing with a patient with serious illness. They might not always, from our earlier research, they might not always stick within their level of competency in terms of what they do. So it's important that they refer promptly when needs be. And also from an assess and identification perspective, which is a big challenge, we used a needs-based approach for identification. And one of our earlier research had created African-specific palliative care needs framework for us to understand the needs that patients come in with in a nuanced way within an African setting. And so parts of the things we do first is to assess using that needs-based approach. And based on that assessment, we know that not all of the patients that come into the primary healthcare settings already with a palliative care needs already have a diagnosis. So that also presented an ethical challenge of how do we address those kind of patients who do not have a diagnosis yet, but we can see that they have the need. So we as part of, next slide, slide 7, as part of the structure of the program, so we included a referral for diagnosis to secondary and tertiary hospital when patients come in with needs. We assess their needs first. We address, maybe it's a pain symptom management that is a major need at the moment. We address that and we refer them for diagnosis, because we cannot admit patients into palliative care when they have not been diagnosed with a serious illness. But we do acknowledge the fact that they might have the needs and their disease condition might be a serious illness. So after that, also the conditions that we included within our intervention was patients with cancer, patients with stroke that still have limitations in their activities of daily living, patients with multi-drug resistant tuberculosis, and patients with heart failure. So those are the 4 categories that of patients that were included within our program. And also we have referral to specialists, palliative care. Usually we establish the referral link for opioid access and for complicated symptom management. And also we have a referral link to NGOs and community-based organizations for practical needs and family support or financial support where it's needed within the program. So and then the follow-up as well is being done through that. So we continue to work to see how to scale this up. Currently, it has been integrated within 3 primary healthcare facilities in well, one of the largest cities in the country, but it requires broader scale up and broader understanding. And one of the challenges we are having is electronic management, electronic care coordination through one patient, one record sort of system, because it's difficult to coordinate care when the records that is being kept at the secondary healthcare facility or at the tertiary healthcare facility is different from the ones at the primary healthcare facilities, and it's difficult to really coordinate that. So that's my presentation, and I want to say thank you to my colleagues from King's, from Edinburgh University, and our collaborators across different African countries where we've worked. Thank you.
Yeah, thank you very much, Odalayo. And I'm very happy to present you the next speaker, Shamat Fernando from Asia. Welcome, Shamat. Hi, Shamat. Okay.
Hello, everybody. It is a privilege to be among you once again. So I'm here to brief about what primary palliative care looks like in the Asian region. So I would start off with giving you an overview of the Asian region, the status of primary healthcare and palliative care, our special interest group's aspiration to map primary palliative care in our region, finishing off with an example of a successful model. The Asian region is home to almost 60% of the global population and constitutes the Southeast Asian region and the countries of the Western Pacific. This map illustrates how different countries in the world have achieved levels of their palliative care development, with more darker shades representing higher levels of palliative care development. And if you focus on Asia, there are countries from no known palliative care activity to countries who have actually integrated palliative care into their health system in an advanced manner. Special interest group on primary palliative care of the Asia Pacific Hospice Palliative Care Network has a plan moving forward as to what we want to achieve in the region. A team led by Dr. Teguh Perdamaian from Indonesia is conducting a survey where we aim to understand what primary palliative care looks like in the Asian region. So we aim to identify the primary healthcare models, the current practices and initiatives for primary palliative care development, and the population needs. Observations arising from the World Health Organization and other researchers come up with how primary healthcare functions within the Asian region. Moving forward through this survey, we aim to understand where palliative care sits within the primary healthcare frameworks. Here we are learning from our colleagues, and our vision is quite aligned with what Dr. Afolabi and colleagues did in Africa, where they
Sorry, I'll get that video back.
Really, it looks like we miss Joan and the video, but she's working.
Sorry, I'm gonna get.
Okay, you are again here. Okay.
where palliative care sits here we are learning from our colleagues, and our vision is quite aligned with what Dr. Afolabi and colleagues did in Africa, where they mapped the existing model of primary palliative care, which is shown on the left here, and then the model that they aspire to develop in the region. So the second model that they envision is quite integrated with the communities, homes, non-governmental organizations, and secondary and tertiary levels of care. Now we move on to exploring a successful model on primary palliative care from within the Asian region, India. So India is a Southeast Asian country with a population over 1.4 billion and a three-tiered health system, primary, secondary through tertiary levels of healthcare. In terms of palliative care development, it is between 3A to 3B. Why I say so is in certain areas where there is a successful model being implemented, there is generalized provision of palliative care, whereas in some regions, palliative care is not as much developed. We are to look at a country level model, but here we start with a model that an individual organization came up with in the early 1990s. So the Calicut organization of Kerala, as published by Dr. Rajagopal and Dr. Suresh Kumar in this image, they have kept the patient right at the top of their model, followed by the supporting family members and the community volunteers, which is something that not all the palliative care models have this element of volunteers. So we are going to discuss more about that later. And then all these three elements are supported by the government hospital and the non-governmental organization, the Pain and Palliative Care Society. Within this model, the community volunteers form a unique element who support with establishing palliative care units, home visits, running outpatient clinics, administrative work, raising funds to function these units, and mobilizing support for the patients from governmental and non-governmental organizations. Because of the involvement of community volunteers, these palliative care units render beyond clinical services, food for the starving families, education for the children, transport facilities for the patients to get abroad from the primary care centers to the tertiary care center and so on, and equipping family members for income generating activities, financial support in emergency situations for the poorest of families. And community volunteers are sometimes trained to provide psychosocial support for the patients and families, and they also form a link between the patients and the local social or religious organizations, and then also non-governmental schemes. It was important to note that right from the inception, this model was functioning on several important principles. The patient's needs should come first, not the organizational motives. If it does, people end up building monuments, helping a handful of patients and becoming gods to keep the others out. Secondly, the average villager is quite capable of making brave and intelligent decisions regarding treatment options, so not to confuse between the patient's level of literacy and their intelligence. Volunteers, as you would have seen, form the backbone of palliative care delivery in the society. Fourthly, religious and social convictions of carers or organizations should never be imposed on the patients. They have stressed on the importance of building awareness among the public about palliative care and the services rendered for them to reach out whenever in need. Then about the fair distribution of resources, quoting them, expensive equipment or drugs such as sustained release formulations are justifiable only if their use does not subtract from the services available to the very poor. And finally, to coexist with the alternative systems of medicine such as Ayurveda, because people tend to receive care from these alternative sources of medicine as well. So very importantly, in 2018, the Indian Association of Palliative Care and the Academy of Family Physicians of India came up with a joint position statement to foster policy, education, and service delivery considerations. So I think it is very important to note that they have really touched all four aspects of palliative care development through this joint position statement. Here is the currently working model on palliative care in India. So it has 3 levels. I put the pyramid there to show how the community level functions at a massive scale at the foundation, and the specialist palliative care centers or individuals right at the top of the pyramid, and the primary palliative care forms the middle layer that provides care while also forming a link between the specialist and community services. So the primary palliative care team, which may also do home visits, community visits, have a core team, general practitioners, community nurses, and social workers. And depending on the context, there could be other professionals and individuals involved in an extended team. So it was very important that they understood what challenges they faced and what were the facilitators as they implemented this model through audit and research. So it is very important to learn all that moving forward. In recent publications, it was stressed that the Indian model functions on 5 core aspects of a successful model. So that is good interpersonal communication, knowledge and skill enhancement, clearly defined roles and responsibilities, especially between the specialist care teams and the primary care teams, a streamlined referral and back referral system between the specialists and general practitioners, and assurance for a continuous and coordinated support for the patients, families, and carers. Moving forward, they are developing a web-based application for the primary care physicians or clinicians to access information about palliative care management, and also do an online form of training for these physicians. Thank you.
Thank you very much, Shamat. We will move to Latin America, where Nicolas Davibovich will present another successful model. Welcome, Nicolas.
Thank you very much. I'll share my screen now. A second, please. You're all... Are you watching my screen now?
Yes, fine.
Okay. So thank you very much. I'm very happy and grateful to be here presenting the experience introducing primary palliative care nationwide while I coordinating the National Palliative Care Program during those years. I think that the model I'm going to present represents part of the situation we are living in Latin America, and as a proposed model for a palliative care implementation at the first level. So, 600,000 patients would have benefited this year in Argentina with a palliative care approach, and only 14% of that demand was satisfied, according to the Ministry of Health. Our country is very heterogeneous in its resource distribution and health system development. Some provinces have high health standards and others are undeveloped and suffer serious lack of health services. There is also inequity in the services provided regarding who is financing them, either the state, social security, or private. So we can assume that most of these 14% were wealthy patients in wealthy regions of our country. I think that this situation is similar to what happens in many undeveloped and partially developed countries in the world, but mainly in Latin America. We still face barriers in the access to palliative care throughout the country. The main geographic barrier is that specialized palliative care teams are concentrated in the main cities, with no palliative care services at the countryside, which means that many patients have to move to main capitals of their provinces just to die with their symptoms relieved, away from their homes, families, and effective environment. Palliative care teams are still fragile. They are scarce, usually incomplete, lacking some important disciplines like psychology or social work, and have much more work and patients that they can manage. The work overload, together with fragile contracts, part-time jobs, and scarce salaries, turn out in frequent turnover of team members, and as we could see, they are not enough. Considering this situation, primary palliative care presents a unique opportunity to satisfy that demand. And we can see how primary care and palliative care share common values and a similar situation. One of the main barriers when addressing primary care stakeholders with the idea of assisting palliative care patients at that level is the lack of time, lack of budget, lack of human resources, and the fact that palliative care competes with a lot of other programs already installed at the first level. There is another resistance and fear that assisting palliative care patients in primary care will bring more work overload with the image of the complex cachectic oncologic palliative care patient being referred to the first level. And the message we reinforced is that patients with palliative care needs are already in their outpatient clinic, and that the strategy will only provide them with new and better tools to match those patients. I think that that is the first step to diminish attitudinal barriers towards acquiring new knowledge on palliative care. Within that reality, and considering the 2014 World Health Assembly resolution, we developed the National Palliative Care Strategy and used the WHO resolution not only as a roadmap of what should be done, but also to validate the proposed strategy with the stakeholders in Argentina. And I find this very important because regarding the World Health Organization strategy, talking about opioid medicine, politics, and training, I think that opioid medicine and training are available or can easily be available in most of our regions, but policy is our main barrier now. When there is a political decision, we can see how these programs can be implemented very successfully. So, Argentina is a federal country. Each province has a Ministry of Health and applies its own health policies. So we proposed each province a multi-level approach. The regional strategy would include a high-level officer from the Ministry of Health, pharmacists, opioid regulators, primary care directors, and palliative care teams. It's important to remark that palliative care a primary palliative care strategy must include the development of palliative care teams in regional hospitals as a central part of a primary palliative care strategy. We cannot ask primary care health workers to assist palliative care patients if there is no chance to work in a network with other levels of care for different complexities and promote referrals when needed. As many countries of the region, we face an economic situation that undermines our possibility to develop ideal, resourceful palliative care programs in the first level. Nevertheless, our system still has plenty of opportunities. The program recruited nurses, psychologists, pharmacists, physicians who were already working in the health system. Throughout sensitizing and empowering primary care health workers with the notion and the idea that palliative care is not patrimony of a specialty, but everybody's responsibility, we encouraged and trained around 800 health professionals from all disciplines each year, enabling them to offer a palliative care approach in their setting. So we carried out sensitizing and recruiting workshops in the provinces and offer a variety of online courses. You can see how we had primary specific courses for primary care, and there was one very interesting course that was named Rational Therapeutics at First Level, that we did together with almost 20 universities across the country, where university teachers, professors, together with palliative care specialists, would train first-level nurses and physicians in palliative care. We also have scholarships for bedside training and different educational activities and offers. We published 2 handbooks, one called Palliative Care Handbook for Primary Care, first published by Dr. Graciela Jacob in the year 2012, and a Palliative Care Handbook for Caregivers. This material is available on the internet for the Spanish-speaking population. At last, I want to present this little vital strategy, which is a telephone hotline where every health worker in the country assisting a patient with palliative care need can call during working hours and receive an immediate answer and follow-up from a palliative care specialist. As we offered basic palliative care training to primary care health workers that would work deep in the countryside, perhaps without a team, this telephone line would allow peer consults on demand to help and give personalized follow-up to those health workers assisting palliative care patients. I find it extremely important that the professional's experience assisting palliative care patients is positive, in order to assure that professionals will commit with the next palliative care patient they have. By the year 2020, we issued the National Palliative Care Law, which includes an article which urges the states to design, develop, and implement palliative care throughout life course at all levels of care, and to foment palliative care education at all levels with special emphasis in primary care. We consider it a landmark which should promote palliative care programs throughout the country. And before finishing, I would like to present a state program, Neuquén Province Program, which is a pioneer province in the regional palliative care development that started by the year 2012 and works with teams with different levels of complexity around the province. You can see all the triangles except the blue ones, which are concentrated in the state capital and in a very important city of the capital. Yes, those are the hospital-based teams, but the rest of the teams are based in the primary care setting. Yes, and they would, and some have full-time dedication, others have part-time dedication, and the violet ones are functional teams that would assemble together when they are patients with palliative care needs. Another Patagonian province, Rio Negro, has an interesting palliative care development as well, counting with 36 functional teams distributed around the province. They are basically hospital-based on the second level, but they work very closely and related with primary care, as many of their members are primary care health workers, and they work with the community and visiting patients at their houses. So these other provinces assist even around 700 patients every year. Just finishing, I bring this image as I think that every step we take in palliative care development in third world countries makes a big difference for our patients. And despite the difficulties we might face, we should bear this in mind in order to keep trying to go ahead and succeed all through the barriers we can find in our way. Thank you very much.
Thank you very much, Nicolás. Muchas gracias. Last but not least, I welcome Jose Pereira to show us the palliative model in Canada. Jose, welcome.
Thank you. Thank you very much. I hope you can hear me well, and I hope you can see my slides on my slide on the screen.
Yes, I can.
Okay, fantastic. Well, Tanya, thank you very much. And Scott, thank you very much for the invitation, and to the EAPC as well. So I'm Jose Pereira. I'm professor in the Division of Palliative Care at McMaster University in Canada. At the moment, I'm in Navarra, in Spain, and I'm the scientific advisor and co-founder of Pallium Canada. And what I was hoping to do today was to share very quickly the state of primary palliative care in Canada, which is a tall order in a few minutes only, because it's a very large country with many different primary healthcare systems actually across the country. And then share with you our experience with Pallium Canada, the approach we've taken, and the impact over the years. But before I do that, I think it's important to understand some of the context here. So Canada, as you all know, is a very large country. It's got 6 time zones, which I think speaks to its size. It's got 38.2 million inhabitants, of which about 80% live in this close, about 200 to 300 kilometers just above the border with the United States. And you may ask why? Well, because the north gets very cold and becomes rural and very remote. There are 14 healthcare systems. So there are 13 provincial and territorial regions, so 13 provinces and territories, and then there's one healthcare system that's run by the federal government. The healthcare organization across those provinces and territories, given that this is a federal system, are different. And so there are different priorities across the different provinces and territories, and funding is different, the models are different, even the primary care models are different. So in Alberta, for example, you'll find concepts such as primary health teams or networks. In Ontario, you're going to find variations of models. Some family doctors and primary care providers work in what's called patient enrollment models. Those are patients rostered to a practice with a salary type of funding. Others are solo practitioners or work in small teams. And even within the province of Ontario, there's a lot of variation from sub-region to sub-region as to what models unfold. So, state of primary palliative care in Canada. We've struggled a lot with what to call the different levels. So we've landed largely on, over the years, in speaking about specialist palliative care and then primary level or generalist level palliative care. As we've engaged governments and other policymakers and governments and health ministries, it becomes difficult if you've got very varying languages and terminology. So we've been using so far the term primary palliative care to relate to not only palliative care provided by primary care providers such as family physicians and home care nurses, but also to include palliative care provided by different specialist services like pulmonology, cardiology, neurology. But I think as we're moving ahead, we're probably going to start using the term primary palliative care more specifically to designate palliative care provided by primary care providers. And for the others, we still have to come up with a good term, but for the time being, we talk about the palliative care approach, where the palliative care approach is palliative care provided by non-palliative care specialists, and specialist palliative care is provided by specialist palliative care providers. And as others, we really highlight the importance that it's everyone's business, and there's got to be a good synergy between those different levels, those 2 levels, and a lot of collaboration. And importantly, we highlighting a lot more the community and the public health approach to palliative care, where one mobilizes the community as well as part of this primary palliative care response. If we look at the healthcare professions, the undergraduate training, so in medical schools, for example, we've come a long way in the last 20 years, but there's still a long way to go. So if you look only at clinical rotations, now I'm not speaking about workshops or lectures or other forms of learning, specifically with palliative care rotations, only about 30% of medical students in 2016, 2017 had an opportunity to undertake a palliative care clinical rotation. And rotations are obligatory in 2 schools and optional in 13. If you look at postgraduate training, which is now when they're specializing, when the physicians are specializing in family medicine in 2016, 2017, just I get close to 2/3 of the trainees underwent palliative care rotations, which means many others did not. And clinical rotations vary a lot across the other specialty areas. 31% of internal medicine residents, for example, completed a rotation. This is a study that we did and we are hoping to publish soon, asking family medicine residents across the country if upon completing their family medicine training, they would be providing palliative care as part of their practices. And what was surprising was the variation. In one school, for example, only 45% of the family medicine residents said that they would include palliative care as part of their practices, whereas in another school it was 80%. And so the question is, what are the factors that influence why so few in one school see palliative care as part of their practices, whereas in others, many more say that it is part of the cradle to grave, the comprehensive care, continuity of care that is supposed to be provided by family physicians and primary care providers. This is another study, international study with several OECD countries, and the question was asked of general practices whether they were ready to provide palliative care. And in Canada, only about 42% of practices said yes, they're ready to provide palliative care. Now, there's not enough time to go into what may be the factors around this. The good news is that 40% are doing it, or 42% are doing it. And I think that is the narrative, that there are quite a few doing it. So how can we get many more others incorporating palliative care as part of their practices? So who provides primary palliative care across the country? Well, it varies enormously across the provinces and the regions. If you look at rural regions, it's provided by the family physicians and primary care nurses, nurse practitioners in those regions, because generally there isn't anyone else to do it. But in most parts of Canada, there's some access to a specialist palliative care team for advice. In terms of in the more urban and suburban regions, primary palliative care is strong in provinces like Alberta, Nova Scotia, New Brunswick, and Prince Edward Island. Variable in Ontario. If you look in Ontario, the most populous province, some regions, most of the primary palliative care is actually provided by specialist palliative care teams, and other regions, family physician clinics and family physicians are providing primary palliative care with the support of palliative care specialists. In 2014, 2015, we started a lot of work in training paramedics in two provinces, New Brunswick and Prince Edward Island, and that has now become almost happening across the whole country. And we're seeing some really interesting, very positive results from that. If you look at Ontario, this is a study we published a few years ago, and we undertook a survey of primary palliative care teams called family health teams and community health centers. And what was interesting was when we asked these teams, and these teams are funded, the model, so not all teams in Ontario have this model, but this model is funded basically to be interprofessional teams to provide a comprehensive care, continuity of care right across the lifespan. And when we asked these teams who provided palliative care, 44% of the teams in Ontario said that they handed over all the palliative care to a palliative care clinician or team, which means that 56% of them are doing it, but 44% are handing it over to a specialist palliative care team. And I would argue that on the long term, that will not be sustainable if there's so much reliance happening on a small group of palliative care specialists. In Eastern Quebec, where we also did the survey, interestingly, most of those primary care teams were providing primary palliative care. It's interesting in Ontario, you see this debate happening where there's a group of folks, and I include in that say, yes, primary care providers can provide palliative care provided they have training and they've got the supports and they've got resources. There's another group that says only a small proportion can do it because they're too busy and they don't have the skill sets. So interesting dynamics. When we looked closely at in some regions who's providing palliative care. And we first went to specialist palliative care teams. We often heard these teams saying, yes, we collaborate with primary care and we work with them. Yet when we looked a little bit closer under the microscope, we found that in some cases the collaboration was largely just a note to say, this is what I'm doing with the patient, this is the treatment I'm doing. So we've developed this model, this conceptual framework, to go more deeply into how specialist palliative care teams, the models they're working in, because in some cases they do consultation, in other cases less so, shared care, but sometimes takeover. And in some parts of Ontario, it's largely takeover. Now, why is this important for primary care? Well, it has a direct impact on primary palliative care, because if specialist teams are taking over all the care, then it's not going to build primary palliative care capacity. So the good news is there are regions where primary care capacity is being built, and partly through policy changes, support structures, and also training. And so that brings me to Pallium Canada. So we were founded in 2000. We're a nonprofit foundation. Concept testing occurred really in 1997 through to 1999. Pallium Canada has got three big programs. The first is called the Learning Essential Approaches to Palliative Care, or LEAP, and that's courseware, and I'll come back to that shortly. We've also got a palliative care echo program going across the country, and way back in 2001, we were already working on trying to stimulate the development of compassionate communities across the country. The concept is published in, or the description of Pallium Canada is published in the British Medical Journal Supportive and Palliative Care in 2021, so I refer you to that. Over the years, we've trained just over 60,000 healthcare professionals on the palliative care approach in primary care, as well as across different settings, including hospitals and long-term care facilities or nursing homes for the Europeans, and also in different specialty areas. This is the suite of different LEAP courses that we have, and you can see there's some that's targeting primary care, like LEAP Core and LEAP Mini. There's a LEAP for long-term care. There's a LEAP for hospital. There's pediatrics, paramedics, surgery for professionals working in nephrology, professionals working in oncology, caring for patients with advanced lung diseases, advanced liver diseases, heart disease, etc. And we also actually have a LEAP for leaders on how to train healthcare managers and leaders on what is palliative care and why is it so important. These are all 1 to 2 day courses. We've got, for most of them, they're available either as classroom versions or fully online versions or hybrid versions, using a flipped learning model. Most of the courses are interprofessional, and they're all available in English and French. And this is what the map looked like in 2019 of the learners across the country. So in 2019 alone, we did 560 LEAP courses or sessions across the whole country. You can see way up even into the north with 9,000 learners. And recently I was asked, well, what happened in the pandemic? Well, this is the map in 2021 in the middle of the pandemic. There was quite an increase in interest in doing palliative care training. So this map again reflects learners across the country. And since then, the map has become even more dense for 2022 and for this year. We've seen impact at different levels, micro, meso, and macro. And by that I mean at a micro level, for example, it's a family health team or a family clinic, primary care clinic that said, let's train up all our folks on the palliative care approach, and have used the LEAP program. The LEAP program also promotes things like quality improvement, because it's not just about the education, you then have to implement into practice as well. Examples of meso level is a hospital, for example, taking up training their staff, or a nursing agency training all their members. Macro level are examples such as in New Brunswick and Prince Edward Island, where the government trained up all the paramedics on the palliative care approach using the LEAP program. So what have been the facilitators of spread and scale up? Well, first of all, healthcare professional, palliative care professionals across the country that have an off-the-shelf, ready-to-go courseware has helped a lot. They don't have to sit and reinvent the wheel and develop curricula from scratch. They can use this. The other important facilitator has been a big train-the-trainer model and program, and we've now got over 800 trained facilitators across the country. Most of them are palliative care doctors and nurses, social workers, and then also some other professions. Collaborations across the country have been important. Flexibility and adaptability to adapt and to take on new opportunities that arise. For example, with the pandemic, there was a call and we really had to pivot a lot to online, but at the same time as well, we were able to get into many other of these meso and macro level health services. Strategic partnerships have been critical. Hospital groups, home care agencies, provincial governments, provincial sub-regions. Importantly, resources, staff, and for that funding has been required. And so we've developed a social enterprise model with revenues coming from different sources, including registration fees, licensing fees, etc. And all that money then goes into supporting the ongoing development and spreading and scale. Another very important facilitator has been the IT infrastructure. And I just want to show you what that looks like. So this is the actual IT infrastructure ecosystem of Pallium Canada. And we've developed this framework, this system of different software platforms to help us with different functions and different tasks. So the online learning management system that we use is Moodle, and that's been modified to our needs, but we've got other things such as Drupal, for example. So managing all the content in those 23 different versions, course versions, multiply that by 2 or 3 for the online classroom, etc., becomes quite a job, especially if you're always updating, changing, bringing in the new evidence. So that helps us a lot. And the red cap at the bottom helps us a lot with the research. And so we come into to impact very quickly. We've published several papers, some of them looking at changes in learners' knowledge, attitudes, and comfort, pre versus post. We have used a system, a method called commitment to change. So at the end of every course, every learner is asked to commit to identify 3 or 4 things that they will do differently in their practice as a result of undertaking this training, and then they commit to it. This is all entered online in the learning management system, and 4 months later, they get an email saying, this is what you promised to do 4 months ago. Did you implement it or not? And if you did, please provide examples of what the impact of it was. If you did not, what were the challenges? So 73% of commitments were reported as having been implemented. And this is a list of some of the top things implemented. So early initiation of palliative care, better use of opioids, better screening and identification of patients' palliative care needs, better pain and symptom management, grief and bereavement care improved, and advanced care planning improved. So I'm going to jump now to finish up. In the paramedics program, we also looked at return on investment and found that by training all the paramedics in the provinces over 9 months, we were able to actually effect a $2.4 million savings. And the savings was made by fewer patients being transferred to emergency rooms. We've developed quality improvement toolkits so that the primary care teams can use the model for improvement in their practices, and people go through these steps on how to undertake quality improvement in their practices. We've studied now in-person versus online and the impact, and found actually very similar impact between the online courses and the classroom courses. I spoke about the ECHO program. I won't go into that in detail, except to say that the number of attendees in the ECHO programs has grown enormously from when we started in mid-2021. So we're now at about 16,000 attendees. So to end off, variability across the provinces and the sub-regions in terms of who provides primary palliative care. We've seen significant uptake across the country of the Pallium courseware. And we still have, though, a long way to go. And this is the diffusion of innovation model. And we think that in some cases, we've gone over the tipping point. In other cases, we're still trying to get to the tipping point. Thanks very much.
Yeah. Thank you very much, Jose. Well, I'm amazing for the amazing work that you are doing around the world. This is fantastic. And I want to invite Dan, please, to wrap up our session.
So thank you. We've had many really fascinating discussions, presentations from all around the world. It's there's just so much in it. I think we're all going to be going back to the video when it's available in a couple of weeks' time to have a look. I just wanted to try and just bring things together just a little bit. A lot of this stuff we've looked at already, just to say that actually primary palliative care within primary care is becoming being seen by the WHO as being a way that palliative care for all can be achieved, and I think clearly from Oladayo's presentation, in places like Africa, where all of the low-income countries are in the world now, apart from a couple outside, primary care is maybe very poorly developed in many countries, and therefore it's quite difficult to provide palliative care in a primary care level. Whereas obviously high-income countries, as we've heard from Jose and Scott, there's quite a lot going on. Very interesting, I guess, middle-income country like Argentina, with really interesting work going on there. But I think it's important that we recognize that the Sustainable Development Goals and the Astana Declaration very much looked at primary palliative care being provided within the primary care level. I'm not quite sure we're going to achieve universal health coverage, including palliative care, unless we do it like that. And there are some very useful publications. There's been a question about what to use. I would suggest you take a screenshot of that and download these resources. I think they're very useful if you're thinking about setting up primary palliative care. We've talked about the definition. Primary palliative care is palliative care practiced by primary care workers, we run into a big problem when we see that actually primary care is very disparate. It's very, very many different models provided by doctors, non-doctors, GPs in high-income settings, or if you go somewhere like America, obviously, to the USA, they don't really have a primary care system in the way maybe that Canada or Argentina or the UK does. So it's quite a challenging area to define. But I think it's important that we go back to the attributes of primary care as defined by Starfield: first contact, continuity of care, comprehensiveness, coordination, and then family-centeredness, culture, competency, community orientation. And of course, a lot of these are shared with palliative care. And another thing is communication, that actually, although communication is important across the healthcare, it's particularly been highlighted and developed in primary care with Balint back in the 60s and Cicely Saunders in palliative care. And I think, though, that there are challenges here. The second part of the definition says integrating identification and triggering of palliative care early in the illness course. Specialists are presented with people with diseases. Primary care practitioners are presented with people with symptoms. And actually, they're the ones that can identify people who have palliative care needs at the beginning. And in many low-income countries, people present really late. So actually, they are presenting with palliative care needs before a diagnosis has been made. And then it's about integrating palliative care within chronic disease management. And I think that's where palliative care and primary care very much link together. In a sense, as a GP, you don't divide off, oh, this is palliative care and this is treatment. Somebody's actually getting care across the spectrum integrated. And then The other thing is strengthening professional capabilities. I think in primary care, a lot of practitioners do not have all of these skills that Starfield identified. And actually palliative care is a way that actually these can be taught. We found this in Nepal with primary care workers, that actually teaching them communication skills for palliative care helps them with all of their practice and not just with the palliative care. So the questions to consider are, how do we want to define primary palliative care? Is there a distinction between palliative care approach and generalist palliative care? What are the essential elements of primary palliative care or palliative care within primary care? And then how do we coordinate this across the global different settings? And we've heard so many different sort of settings. How can we actually distill this down? So I'm going to ask each of our panelists to comment on those, well, to pick one of those and to just maybe just a minute just to answer that. So let's go to Scott first, because he started first, and Scott there.
Yes, thank you so much. I hope you can hear me. Thanks for the great presentations. I've learned so much today, and even what is within the primary care setting, especially volunteers and paramedics. But I think the approach we want to be when we say how to define primary palliative care, we want to be quite pragmatic, or have a pragmatic paradigm. There is an issue, people are getting a bit confused. How can we work it through so that we can take forward generalist palliative care by professionals and volunteers in the community? So I think the idea is not an academic exercise on the definition, it's what will best allow us to facilitate this approach, the principles of palliative care, especially within the primary care setting. And of course, in other settings as well, just as the GSF is attacking hospitals and other places as well. So I think being pragmatic about the definition. Yeah, but I've learned so much today about new areas as well. Our paramedics, I mean that's a great inclusion, where would they sit? Thank you.
Oladayo, perhaps would you like to respond to that? I think you've done a lot of work around thinking about the definition of primary palliative care, and how do we get the balance between actually being realistic and being aspirational in terms of where we go with palliative care in the primary care setting? Are you there, Oladayo? Okay.
Yes, I'm here. I'm here with you.
Did you catch the question?
Yes. So in terms of really being pragmatic, and I think that's what is really important within how we define palliative care at the primary health care level. And I like the second question around whether there's a distinction between palliative care approach and the generalist palliative care, because I think that is really what is creating some of the confusions that we've seen. Because I think from my point of view and from our research, that these are really the same. And it's really having that understanding that primary health care, in terms of the structure of it, in terms of who works within it, is going to be different from country to country, and the competencies that those healthcare providers within primary healthcare are going to have is going to be different from country to country as well. And the risk we run into in defining primary palliative care as palliative care within primary healthcare alone is the exclusion of palliative care that is being delivered within other levels of care, but that is the first point of care, which is not also specialist palliative care, because like I mentioned, with the weaknesses in the healthcare systems, patients can sometimes go to the tertiary healthcare facilities, which is their first point of care. And I think that ties in well with the attributes of primary health care that you showed from that paper around point of contact, first contact. Thank you.
Thanks very much for that. I think, I wonder, what are the essential elements of primary palliative care then? Perhaps Nicholas is from the Argentinian perspective. What do you think would be the how would you sort of summarize those essential elements?
Thank you, Daniel. I think I agree with what Dr. Oladayo just said. I think it's the art of the possible in our setting, and that our first step here is to install the idea of that palliative care can be managed at the first level. And I think that the essential elements, as Jose Pereira just said, is that primary care and palliative care share a lot in common. We don't have to teach a lot of communication skills. We don't have to teach about the importance of patient and family as a unity. And the basic symptom management, yes, and the basic symptom management is the first, and it's not enough if you want a broader image, no, but it's the first simple step that can be achieved with basic training, basic online training, and I think that's something third world or countries in development can achieve, and can achieve easily, and can achieve today. So I think that is part of the answer. I think it's what's possible, and not what's just the best we can achieve.
Yeah. Okay. Well, we have to be aspirational as well. We have to.
Sure, we have to have that horizon in mind. But if we want to, I think in our region, if we want to install the full package or the full idea, then we will have so much resistance, or that's what I faced when doing it in the country, that they said, no, we cannot. But they say, okay, just learn how to treat pain, how to manage symptoms. Do it with the patients you have today in your clinic. And when they start to be comfortable with that situation, then we can go further in our aspirational horizon, no?
Yeah, that's great. That's really helpful. And I'm just interested in the concept of integrated chronic disease management. Anyone want to talk about that? If you, Kerry.
Well, I was wondering, I mean, we're talking here, of course, about primary palliative care with the understanding that we all have of what palliative care is. But I think if you, I really enjoyed the African and Latin America and Asian contributions, but the Indian Kerala example was start with the people. And that's what we felt we've done. And the people, it depends on each country's current demographics and things, but with us in the UK, we're shifting to age-related conditions, frailty, dementia, comorbidity, and is the palliative care approach quite as useful in that context, or who is the best person to give care for people in the last stages of life? So the query would be, what is the role of each of us to give? So I just think that rethinking this in terms of age-related conditions, which will be increasing as longevity is increasing across the globe, unless we have a terrible pandemic again. And then the other terms that I noticed the BMJ is called supportive and palliative care. There was a nice guidance in supportive and palliative care. Somehow some people, I think, in our country think When you say palliative care, you mean refer to palliative care. We spend a lot of time asking people not to think like that. Don't think refer to palliative care. Think, what can you do? So a cardiologist or intensivist and renal physician. And so what are you doing to care for someone who might be in their last years of life? Orthopedic surgeons, you know, where 30% mortality of total hip replacement. So the term supportive care, some people might not like, but it might be a little bit more inclusive. I think the term end of life care, which is what we use in national policy, can be a bit tough because it indicates dying, but supportive care, and we all do that. So I just think democratizing this, releasing the talents, not thinking anyone has a monopoly of compassion. And yes, we are looking at a service here, but how can we start with the person backwards? Would be my reflection, because in the end, with an aging population, doing nothing's not an option. We you know, financially, over hospitalization, over intensive interventions, it's not an option to carry on doing that when we think of what is out there. So palliative care will have a key role in this, but doing nothing is not an option. We have to persuade people that for economic and other reasons, we've got to do better.
Right. Okay, thanks very much. Okay, I think we've actually run over time, but I think we're allowed to carry on just for a couple more minutes. Maybe just each of the panelists, maybe just to say just a few words in sort of summary about what you've what today's given to you in terms of your sort of thinking. Perhaps I could ask Professor Jose to start with that.
Thanks very much. I feel even more excited about the importance and the need to promote primary palliative care, and by that, and the palliative care approach. This cannot happen without primary palliative care and without specialist palliative care. We need both those levels. Going forward, I think I will use the term primary palliative care to refer to palliative care provided by primary care providers. I see the palliative care approach as the umbrella, of which a component of that is primary palliative care, but importantly, cardiologists, oncology teams, nurses in nephrology, all those healthcare professionals should learn the palliative care approach and be able to do it. And as Kerry said, one of the big challenges we have in Canada, when you hear palliative care, they think of referring to a service. We've got to change that. It's about what can I do, and when is it appropriate, and when is it necessary to get a consult or help from a specialist palliative care team. Thank you very much.
Okay, thanks so much. Chamath, Dr. Chamath.
Hi, Dan. Yeah, thank you. So what I want to do is, like, in terms of primary palliative care, we aim to integrate the principles of primary care with the principles of palliative care. And they're like what are the main functions of primary palliative care would be to coordinate between different levels of care, as well as drawing on the community resources and, you know, whatever the other forms of support from the community, which is not a very alienated concept for the GPs, of course, or primary care clinicians altogether. So I think that coordination part is one of the essential elements of primary palliative care. So even in terms of generalist palliative care, as the other panelists mentioned, like even an orthopedic surgeon might choose to care for a patient with a palliative approach, but that would be different from a primary care physician or a clinician, because that's more, there is a bit of a coordination part that needs to be done from their end. Yeah, thank you.
Okay, thanks, Chamath. Oladiah, perhaps do you have any last words of wisdom for us?
Not necessarily words of wisdom, but yes, I think in terms of the essential components of palliative care, from our research, one of the things we've found within low and middle income countries is lack of information about the disease condition that the patient is even going through. The patient don't know what their disease condition is. They don't know what to expect. The family caregivers don't know anything about it. Some of the patients we interviewed will say, they said, I have the heart thing, but they don't really know anything about it. So communication was one of the very important key elements that we built. Education about the disease condition, about the cause of the disease was one of the very important elements that were built into the model that we evaluated in Nigeria. And I think that's really, really important. And when we think of disease models, like how HIV was integrated within healthcare systems across Africa, there were structured education materials given to primary healthcare providers to be able to educate patients and family caregivers about these things. We don't have those structured education materials for serious illnesses like cancer, like heart failure, and things like that for primary healthcare providers to be able to use to provide education to patients and to family caregivers. And I think those are also very important to consider.
Yeah, okay. So much to do. As they say in this part of the world, how do you eat an elephant? One bite at a time. So, okay, I'll hand back to Tanya now to close. I think we need to close.
Yes, also thank you very much for your intervention, for your contribution, and also for the people, for all that you are attending to this webinar. I heard that is a lot of other questions that we couldn't address in this time, but I see also that is a need for continuing this discussion and to have other possibilities to exchange like we are doing now across the world. It's really exciting to have this opportunity. Well, I thank you very much, and I hope we see us each other very soon and to continue that. Thank you very much. Thank you. Thank you all.
Thank you.
Hi, everyone. Thank you so much. Nice seeing a lot of the old faces again. Thank you.
I hope so. Ciao.
I'll be in touch, Kerry and Scott.
Yeah, less of the old, Jose. We're all aged.
I convinced me on that one.
That was great. Well, hold on just a wee minute. It's interesting, Chamath said principles of palliative care, which is a vocabulary that I found some hospital doctors, would publish right rather than approach. So it was just a comment on that. He's picked up on that. But, and I think we've learned a lot there, really, about that. But the idea of choosing something or some description so that we can take forward. I mean, generalist palliative care is a term that's pretty common. But Josie, I'm interested from your comments about, say, you might come back, because we don't want confusion in primary palliative care, the earlier definitions. I mean, I had Amy Abernethy across to Edinburgh once because she was so good about generalist or primary palliative care to speak at a big cancer conference. And that was great, and I don't want to discourage that approach. But there is a bit of confusion there, isn't there?
Yeah, there is some confusion. But I think we shouldn't get caught up with that. I think we should just the key message all the time should be everyone should have these basic core skills, and whatever we call that. I mean, for me, the palliative approach term captures that the umbrella, that concept well, and I think that's the key thing. In Canada, generalist level doesn't seem to be resonating a lot, because we don't use the term of GPs or general. And then when you mention that to the specialists, the oncologists, the nephrology teams, the nephrologists, they don't connect with that at all. No. And they don't connect with primary palliative care. They don't connect with primary level palliative care. So I think David Currow and the folks back in Australia in the early 2000s were spot on when they started to think of that palliative care approach. Because it's interesting, I was speaking to a group of respirologists recently, or pulmonologists, whatever you call them in your part of the world, and they were saying, well, we provide palliative care, period. So just palliative care approach, the principles of palliative care provided by all.
I think in my experience, some GPs say find it a little bit insulting to assume that they don't have compassion and good communication skills. Of course, we know there's a spectrum, but I also wonder I know there aren't geriatricians in every part of the country and in every country, but their bread and butter is caring for people nearing the end of life. And I'm working with them a bit more closely, and they don't always see palliative and end-of-life care, because it doesn't, palliative means referral, but that's why I think, and also our Chief Medical Officer, Chris Whitty, about 10 days ago, produced a very interesting report about the future of our health service in relation to the age-related conditions and our aging population. It was fairly devastating. And he put there, we need more generalists. But personally, we find the term frontline staff easier. These are the frontline people who are there, you know, in health and social care. And there are 1.8 million in social care and 1.2 million in healthcare. And actually the social care for people with dementia are so much more important. The domiciliary care, the care homes, and how they care. So GSF principle is about training them to be as good as they can be, rather than. So I think there's something about the age-related conditions that's going to. I mean, Irene Higginson did some work on it, showing that 40% more deaths in the next 20 years, 25% more deaths by 2040, and so many of them, you think, well, do they fit into a palliative care category? And they won't necessarily. So I just think we've got to be open-minded to the roles of others.
Yeah, we could get in the back. Chris Whitty was deriding our hospital doctors, not for not doing palliative care, but for not doing any generalist medical care that they used to do, you know, when they were hospital generalists. Mm. So there's even an issue there that's interesting too. We could.
Scott, I was curious about the concept of supportive palliative care. I think it's brilliant. In fact, in the LEAP courses, we're teaching people to call it supportive and palliative care. And when we're doing this with a cardiologist, nephrology team, etc., it resonates with them. Yeah. It makes it easier. It opens up doors. So I think that concept is something that we could even home in more on, I think.
I know it sounds bad to be a bit averse to the P word, but it just, you don't want anyone to say, oh, that means refer on. So we trained cardiologists, they've come back for reaccreditation, and they're so proud of the clinical care they give to their dying patients with cardiological, and they only refer when needed. And they're supported by the palliative care team. So it's like a tertiary service supporting the frontline staff. So gradually, if we get cardiologists on board, then there's hope.
I like very much the approach of Nicholas. He said, well, if I can quote you, Nicholas, he said, we are supporting you to treat the patients that are ready in your waiting room. As this is very encouraging, as an introduction for palliative care for the GPs. No? As I quote, did you write, Nicholas?
Yes, it was something like that. It's I've been giving many presentations around the country, and I felt more like going with the with the Bible and trying to put everyone on board. And I think that it's just showing the need and confronting them with what would you prefer if you were a patient. Would you need a refer for someone to treat your pain, your dyspnea, or would you prefer the first doctor at wherever you are to solve your problem? So if that's what you prefer, then that's what you should achieve at your setting. No, so I think it's when you say treating pain is easier than treating a cardiac failure, or I think that there is I think the speech should be to diminish the resistance we find in people receiving this knowledge, because the knowledge is easy to receive, it's easy to understand. They have gone under a university degree, and there is so much information today that I think that we should focus on sharing that information. I think these groups are very interesting in that approach, because I see many programs in Latin America spending a lot of time writing their own courses, preparing their own presentations, and that's nice, and that's always interesting. But there is so much material that today can be shared for an educational purpose, that I think that one important an interesting opportunity of these groups is learning from each other's settings and how they solved their barriers, and sharing information, because I think that it's all written already. And I love these opportunities, because we are always in the mainstream of the information, and we read what happens in Europe, in the States, in the main countries, and having the opportunity to understand and hear the Asian experience, the African experience, is also very, very empowering.
Yes, it's great. In fact, that I see there's 57 participants holding on, listening to the debates, and I'm fascinated too. And in Scotland, you know, rather than talking about do you consider palliative care, we say something, shall we start planning care? Should we do a care plan? And then we would start a key information summary. So the trigger is that planning is maybe the early palliative care intervention that we're trying to start.
And I just wonder, for example, something that's worked for us in converting people's thinking in hospitals would be using the Clark paper, where he's found that 30% of people at any one time are in their last year of life. So you're not saying that's end of life care dying, but they're in their last year of life. And then we do audits of each ward. And it's wonderful that very rarely any ward doesn't have any people in the last year of life. And suddenly they realize this is relevant to them. Not that they've got to care for them as they're dying, but the people that they're caring for might go home and die later, like 30% of people who have total hip replacement. So it's like reframing another language, and the palliative word is often a bit of a barrier. It's good, of course, we know it's good, but it can be a barrier to people taking responsibility themselves. And so we just find that audit, when they've done that, and then they do the same, that's population health, and then do the same with primary care with the 1%. How many of those 1%, you know, are you saying you don't have anyone who dies? And
the bit like a surprise question, wasn't it? It's making people, you know, you'd be surprised if your patient died, you know. It's good.
The surprise question is interesting, because I think, at least in Canada, we've seen some studies that challenge it and say, oh, it's not a good prognosticating tool. And we have to teach, it was never developed as a prognosticating tool. It was developed as a tool to change culture and change thinking and bring it up earlier. And even if you will be surprised if someone is going to be dying within 6 to 12 months, the surprise question, then do they have a serious illness or chronic illness that's causing quality of life issues, in which case they do need, and I'm going to use the word supportive and palliative care. I don't like the idea of dropping the word palliative. And I think, as Nathan Cherney says, we've got to educate people on the word. But I think adding supportive and palliative care just makes it more accessible and brings it earlier. So I'm going to have to run, because I've got a workshop to go give now. So
okay. Well,
thank you for a really lovely discussion.
Thank you so much. Thanks, Daniel. Thank you, Scott. Thank you, Tanya. And we'll be in touch.
Thank you very much to you all. Really very great contribution and really great discussion.